أستاذتي دكتورة علا. أحب أشكر أستاذتنا كلنا دكتورة سناء يوسف على العظمة اللي بتعملها لنا كل سنة الحقيقة، يعني حقيقة عظمة على عظمة يا دكتورة سناء يعني. جزاكم الله خيرا على العلم اللي هو دايما هيبقى في ميزان حسناتك بإذن الله تعالى. وزميلتي الدكتورة ياسمين ودكتورة مروة الحقيقة على الجهد المشكور دايما والتنظيم الرائع للمؤتمر. هقدم أستاذة الدكتورة علا، بروفيسور اوف ميديكال جينيتكس، عين شمس يونيفرسيتي ديبارتمنت اوف جينيتكس. دكتور علا هتقدم لنا Emergung Therapeutic Approaches to Classic Homocystinuria. اتفضل يا دكتور علا.
بسم الله الرحمن الرحيم. قبل ما ابتدي احب اشكر استاذتي الفضيله استاذه الدكتوره سناء يوسف for giving me the opportunity to share in this great scientific gathering. Actually, my presentation today will be on emerging therapeutic approaches to classical homocystinuria. My presentation flow chart will be an introduction, a quick introduction to homocystinuria. Then I'll pass by homocysteine metabolism. Then I'll focus on etiology and genetic causes to help for knowing the emerging therapies. And then I'll concentrate on classical homocystinuria, current and emerging therapies for homocystinuria. Homocystinuria comprises a number of disorders of homocysteine metabolism united by the common biochemical findings of high plasma and urine homocysteine concentration. Hyperhomocystinemia is implicated in a prothrombotic tendency and neurological features associated with all of these conditions. Therefore, lowering homocysteine is a major goal of treatment, which in turn necessitates an understanding of the range of differential diagnosis of hyperhomocystinemia to ensure a correct treatment is initiated. As we can see here in the homocysteine metabolism, homocysteine is intermediary amino acid here formed by the conversion of methionine to cysteine. Actually, homocysteine is metabolized by two pathways. One of them is transsulfuration and the remethylation pathway for the conversion of homocysteine into methionine. And here we can see methionine to S-adenosyl methionine, and then S-adenosyl homocysteine, and then releasing methyl group, which is used for different methylation reaction. And then homocysteine is converted back to methionine. Methyl donor would be 5-methylene tetrahydrofolate, and also betaine, requiring betaine homocysteine methyl transferase. And then homocysteine by the transsulfuration pathway by cystocyanine beta synthase requiring B6 as a cofactor, it is converted into cystocyanine and then cysteine. Etiology elevated homocysteine plasma, total plasma homocysteine is 10 to 15 micromole per liter, which can be elevated due to a variety of conditions involving genetic factors, which I'll focus in the coming slides. Vitamin deficiency such as B6, and the main is folate and B12. Chronic kidney disease, drugs such as fibrate, metformin, methotrexate, and nicotinic acid. Smoking also can elevate plasma total homocysteine. Genetic causes of homocystinuria can be attributed to due to classical homocystinuria caused by cystocyanine beta synthase deficiency, which is the most common form, and also other genetic causes like remethylation defect. I'll focus today only on the classical homocystinuria. As I showed in the previous slides, here we can see for classical homocystinuria, there will be a defect here in cystocyanine beta synthase. There will be, sorry. So we can see there will be elevated homocysteine as well as elevated methionine together with decreased cysteine, and elevated methionine will differentiate classical homocystinuria from the other causes like remethylation disorders, in which those patients they do have elevated homocysteine, but they do have decreased in methionine. Classical homocystinuria due to cystocyanine beta synthase deficiency is the most common autosomal recessive in bone arrows of sulfur metabolism and is associated with elevated plasma total homocysteine and methionine. There is a variety of spectrum of severity and age of presentation. Some patients have a severe childhood onset multi-system disease, while others are asymptomatic into adulthood. Phenotype, very important to know, will depend upon the pyridoxine responsiveness. Very important, once we diagnose the patients, we have to do first the pyridoxine responsiveness test. Pyridoxine responsive patients generally have a milder phenotype and the later onset than the pyridoxine unresponsive ones. The incidence of Qatar, in which classical homocystinuria is the most common metabolic disease there, is 1 in 1 to 400, and it is attributed to a common mutation found in Qatari population. Untreated patients with CBS deficiency, they do have a plasma total homocysteine above 100 micromole per liter. Newborn screening identified early and the start of treatment have a favorable prognosis. Just I want to mention quickly, there is 4 cardinal systems for those patients who, or the complication for homocystinuria. If untreated patients, especially pyridoxine unresponsive, they do have ectopia lungs, which is preceded by high myopia, excessive height and lungs. They do have developmental delay, intellectual disability, psychiatric problems, and thromboembolism, which is a common cause of morbidity and mortality, and it usually it can happen for patients who are pyridoxine unresponsive, but patients with mild form can only discover having thromboembolic manifestations. For the diagnosis, guidelines had been developed in 2017 by Maurice and group of expertise in important areas of metabolism for diagnosis and management of classical homocystinuria, and the guidelines recommended that total homocysteine accompanied by plasma amino acid as a front test for diagnosis, and total homocysteine 100 micromole but occasionally lower together with elevated methionine makes the diagnosis likely. And actually for the newborn screening, sensitivity of methionine as a primary marker for pyridoxine non-responsive CVS deficiency is limited and inversely related to chosen cutoff concentration of methionine. And the sensitivity has been increased once there is elevated methionine. We have to go second tier 2 for total homocysteine. The only lucky persons, those for the Qatari population who did total homocysteine as a first tier for the diagnosis of patients with classical homocystinuria. Classical homocystinuria pyridoxine responsive, I'll just speak quickly, that consensus guidelines suggested that all patients newly diagnosed with homocystinuria, as I have mentioned, has to complete a vitamin B6 trial to determine if they are responsive prior to initiating dietary restriction. Patients detected by the newborn screening rarely respond to pyridoxine. A decrease in total homocysteine less than 50 micromole per liter, or that's to say 30% reduction, suggests the vitamin B6 responsiveness. Once a response is determined, the lowest possible dose of vitamin B6 should be used to maintain an active metabolic control. What about the classical homocystinuria management? Actually, I'll put just 2 slides for the current management, and then I'll focus for the emerging therapies. The goal of therapy for the newly diagnosed patients that I have to start quickly and early to guard this patient to help to prevent the complications to happen for those patients, but at the same time, I have to allow the patient to have a normal growth and development, and this is a great role for metabolic dietitian. And for late diagnosed patients, I have to aim to prevent further complications, especially thromboembolic disease. And the best result, as I said, has been for the treatment shortly after birth and achieving a total homocysteine at less than 120 micromole or preferably below 100, and B6 responsive patients goal below 50. The current management for, or the current therapy for patients with classical homocystinuria diet, most pyridoxine unresponsive patients require a diet that is very low in natural protein, but with supplementation of methionine-free L-amino acid mixture. And betaine, which is, it is a methyl donor used for those patients to attain a good metabolic control, that is to say, acceptable level for total homocysteine. In children, usually start by 50 milligram per kg, and then it is titrated on a weekly basis up to 200 milligram per kg per day, divided in 2 doses, and adults 3 grams twice daily, and B6 100 up to 500 milligram per day for adults. Also folic acid 5 milligram daily, and hydroxycopolamine 1 milligram intramuscularly monthly. But the problem is poor compliance is a major issue. Usually those patients who are for the pyridoxine non-responsive, like the same for cataract population, those patients diagnosed late, so there is poor compliance, so they need a high strict diet. This is usually the major problem. For this reason, as Professor Moin said, that we are hoping or waiting for an emerging therapy that will help the better quality of life of these patients. The most important thing is the relaxation of diet or liberation or make liberation of or dietary management. So the emerging therapy had been mentioned before for homocystinuria and CBS enzyme potential new therapies. The new therapies are addressing the main problem during the pathway. So there will be some of them will act for methionine degradation to prevent its conversion to homocysteine, and there is some of them will act on help for also catabolism of homocysteine, and others for restoring the CBS enzyme. One of them is CDX and the SEN 135, and also formate and thiobase reductase. One of them acts on the GIT, and the others act on the blood, and also beta virulase, which help also acts on total homocysteine. And then for the enzyme replacement therapy, the new hope like big virulase is bictebatinase, and I'll put some short slides for it. And also gene therapy, it's a very important therapeutic for gene therapy, is that it is one and done. For all the gene therapy, we do it, then there is no need to do anything else. Here, as I've mentioned, there is some of them will work on the GIT, current approach dietary methionine restriction, and the novel approach is a synthetic, is a genetically engineered probiotic, and also enzymes. And here for methionine, also earth methionase also help also to prevent conversion of methionine to homocysteine. And as I said, bictebatinase I'll show in the next slide. And also here we can see also chaperone therapy, as we knew before, for other disorders. It helped also to restore CBS enzyme activity, and also proteasome inhibitor, which prevent the breakdown proteasome, as well as gene therapy. I'll put some slides for bictebatinase. Bictebatinase, it is an investigational enzyme replacement therapy for classical homocystinuria, which has been developed by Travere Therapeutics as a potential enzyme replacement therapy. We can see this is a normal pathway, and for bictebatinase, CBS activity is deficient in patients with homocystinuria, which leads to excessive accumulation of total homocysteine. What is bictebatinase? It is a big truncated human CBS designed as the enzyme replacement therapy for homocystinuria, and it is administered subcutaneously injection and designed to be active and stable in the blood. They started actually compose phase 1 to 2 clinical trials addressing safety, tolerability, efficacy, or pharmacokinetics. And I've said it is a first in a human double-blind randomized placebo-controlled dose escalation study to study the safety and efficacy of bictebatinase in patients with homocystinuria. I'll not go deep in the study details, but they started with 6 cohort, and those cohort there is a escalating dose for the enzyme, and the maximum was in cohort 5 and 6, and the maximal dose 2.5 milligrams per kg subcutaneously biweekly, and they found there is a new hope or for normalization or decrease the homocysteine to target level. And most important is that they didn't. The patient has to have a strict dietary management, not to liberate any diet, and to have a close monitoring with dietitian. And here we can see also a patient after finishing a double-blind treatment period, they will go into open label extension. And again, here they showed that the majority of their patients were 24 male, 24 years of age, and 75% of them were male, whereas the race 87% were white race. Here I wanted to go quickly to show that there is minor adverse effect which is related to injection sites, which can be already managed, and they show the relative reduction in mean total homocysteine at the highest dose of 2.5 milligram per kg. BID was 67%, and this will give a potential that will be a new and emerging therapy for those patients. And like what Professor Mouin has mentioned for the Blanzic, that they found that one patient in cohort 6, this patient reached a level of homocysteine to below normal, so they need to add dietary some natural protein or intact protein to this patient to increase homocysteine level. And also here for this slide, they achieved a sustained reduction in methionine in 2 weeks. Also dietary protein intake in the study throughout the 12-week treatment, no reduction in dietary protein intake were observed. And this what I have mentioned about this patient, that one patient in cohort 6 it required addition of natural protein to their diet during the open label extension, and currently with a normal with normal methionine limits, and that's what we actually need for our patient, that we can liberate the protein or relaxation of diet. Here they also some of the results that it was generally well tolerated, and also leads to reduction in methionine as well as homocysteine. And just in one slide, I want to say that there is a harmony study started, which will be, there is a screening period, blinded treatment period, and there will be follow-up 4 weeks for patients who will not continue, who will not enter into ENSWEL long trial extension. And also they will address the primary efficacy with safety or tolerability. In conclusion, the current treatment options for classical homocystinuria are limited and often inefficient, particularly due to low patient compliance with poor strict dietary regimen. Recent program research and development of new therapies for homocystinuria hope for a long-term health benefit and better quality of life of those patients. And finally, I'd like to thank you for listening.
Thank you, Professor علا خليفة. المحاضرة رائعة الجميلة، يعني الكام زي ما عودانا دايما. Now can introduce Professor Khalid Zehli.